Right. Thank you all so much for coming to our monthly Cares About Anxiety webinar. Today, we are very lucky to have Chloe Chessell here, who is a visiting graduate student from the University of Reading in the United Kingdom. So you will get the pleasure of hearing her delightful accent, as well as her expertise on childhood anxiety disorders. And she is particularly an expert on the impact of childhood OCD on the family and how to involve parents in the treatment as well. And so we are very lucky to have her here today, and I think you will really enjoy this talk. If you have any questions during her talk, please feel free to put them in the Q&A box at the bottom. We will either answer the question just by writing it in the box if one of us panelists can answer them, or we will post them to Chloe at the end of the talk. But I will now leave it up to Chloe to continue.
Great, thank you, Anna. Hi everyone, welcome. So as Anna mentioned, this evening I'm going to be giving an overview of obsessive compulsive disorder, or OCD, in children. And in terms of specifically what we're going to cover this evening, first of all, we're going to think about what OCD is and how OCD presents in children and adolescents. We'll then think a bit about how OCD impacts the family, and we'll draw on some research that myself and my colleagues at the University of Reading have conducted to really explore how OCD can impact the family. And then we'll focus a bit on what evidence-based treatment for OCD looks like and involves, and think about how you can support a child who's receiving treatment, so whether that be a parent or a carer or a teacher, perhaps. So in terms of, first of all, thinking about what OCD is, so OCD is a mental health disorder which affects up to 4% of children and adolescents. So around 4 in every 100 children and adolescents will meet criteria for OCD. And so if you think about your child's school, or perhaps the school that you work in, that's a good couple of handfuls of children who are experiencing OCD. And in childhood, OCD commonly onsets around the ages of 7 to 12 years old. And typically what we know is that OCD can persist into adulthood if appropriate treatment isn't provided. So being able to access evidence-based treatment early on can be really helpful in terms of long-term outcomes. OCD is also one of the top 10 most debilitating disorders, and that's when we're including physical health conditions as well. So OCD really does have an impact on the individual and their family system, which we'll focus on a bit more today. OCD also doesn't often commonly come on its own. It often comes hand in hand with other mental health difficulties. So for example, other anxiety disorders or low mood, behavioural difficulties as well, such as attention deficit hyperactivity disorder, or perhaps tic disorders as well. So what actually is OCD then? So OCD is kind of made up of 2 parts. So we've got obsessions and we've got compulsions. So obsessions are intrusive and unwanted thoughts, images, or urges, which are repetitive. So they go round and round in children's minds. And they cause children and young people distress and anxiety. And to give you a bit of a sense of what obsessions might look like, or common obsessions, they typically fall into a few kind of broad categories. So I'll speak you through some examples so you can get a bit of a sense of a flavour of what this might look like in children and young people. So the first kind of category is contamination, which is often commonly associated with OCD in terms of public knowledge of OCD and what it is. So contamination obsessions might include unwanted thoughts or worries about dirt or germs or particular illnesses. Young people might worry that they might get ill or make other people ill because of a contaminant. They might also worry about bodily fluids, pollution, or toxic waste, for example. Obsessions around harm are also common. So this is where a young person might worry about harm coming to themselves or to people that they love. So they might have unwanted images, perhaps, of kicking or punching other children, even though they don't want to, or they might have worries that they might be responsible for something bad happening, like a fire or a flood or a burglary. Religious obsessions can also be seen in children and young people. So that can involve worries about offending a religious figure, or really strong beliefs about things that are morally right or morally wrong. Sexual obsessions are less commonly seen in children, but perhaps start to see them more in adolescents. And again, that can be unwanted thoughts about kissing someone they don't want to, or genitalia, for example. And then also we've got superstitious obsessions as well. So perhaps worries about particular numbers or colours, or worries about good or bad words. Compulsions then are repetitive behaviours or mental acts that a young person feels compelled to perform to reduce the distress or the anxiety caused by their obsession, or to prevent a feared outcome. And so these behaviours or things that children do can be overt, so things that you might notice them doing, or it might also be things in their mind as well that perhaps might be harder to see as a parent or a carer or a teacher. And so again, common compulsions, they fall into different categories, but they can include things like cleaning, so washing their hands over and over again with several pumps of soap. It might be going to the toilet in a particular way, so only being able to go to the toilet if they can shower afterwards, or perhaps taking their clothes off to go to the toilet. We also see as well young children kind of brushing their teeth in a particular way. Checking is also common, so children and young people might check back through their school books to make sure they've not made a mistake, or they might check the door several times before going to bed to make sure it's locked. Or they might check that there's no harm that's come to anyone, so they might check the news, or they might text their parents several times to make sure they're okay. Repeating is also common among young children. So this is where children with OCD can get stuck kind of doing basic day-to-day things over and over again. So they might have to walk in and out of a door several times, or perhaps turn the light switch on and off several times, or get up and down from their chair several times. We also see counting. So for example, a young person kind of counting when they're doing things, or perhaps counting the syllables when someone's talking, for example. We also see symmetry and order, so a need for things to be in a particular order or in a particular place. It's also common that we see children wanting to make things feel even on their body. So if they brush past something on their left shoulder, they would really feel they need to brush past it on their right shoulder to make sure that it feels right. We've also got this idea of doing things until it feels right, which we often see among kind of children and adolescents. So it's simply repeating an action or a behaviour until they get this feeling that it just feels right. So again, it might be turning the light switch on and off until it feels right, or opening and closing a door until it feels right. And commonly as well, OCD can be a bit sneaky, and it can get other people involved in compulsions. So for example, OCD might get other people to wash their hands after touching something particular, or it might ask mum and dad for questions about whether things are going to be okay. And we'll think a bit more about that as we go through the presentation this evening. So I just wanted to normalise that we all experience unwanted thoughts. It's completely common and natural. So you might have experienced a thought of pushing a stranger in front of the train, or perhaps jumping off somewhere really high, maybe worrying that you've left the oven on, perhaps an unwanted thought of driving your car off the road, perhaps worrying that you've not checked the door properly, or worrying about kind of offending a stranger in public. And so experiencing these unwanted thoughts is normal, it's common, and research shows the type of unwanted thoughts that people with and without OCD experience is the same. But what's thought to be the key difference is how we interpret these thoughts. So for example, for someone without OCD, if they were at a train station and they had an unwanted thought of pushing a stranger in front of the train, they might think, oh, that's a bit of a weird thought, brush past it and carry on with their day. But for someone with OCD, they might interpret that thought as an indication that they're dangerous, that they want to harm other people. And it's that interpretation which leads to them experiencing distress and anxiety. and motivates them to engage in a behaviour to prevent that feared outcome. So in this example, they might ask their friend for reassurance that they're not going to push someone in front of the train, or they might stand really far back from the platform so that they're not able to push someone. And so it's really all about that interpretation that's key in differentiating individuals who experience OCD and those who don't. And it's that interpretation that causes the distress, motivates that behaviour, and then causes interference in a young person's life. And we know that OCD causes lots of interference, particularly for the young person and for their family, which we're going to focus a bit more on now. So I'm going to talk a bit about some research that I've done with my colleagues at the University of Reading, where we really wanted to kind of explore the impact of OCD on families. And so we interviewed 22 parents of 16 children, aged 7 to 12 years old, who'd experienced OCD. So we interviewed some parents of the same child. And we were really interested in exploring what is it like to parent a child with OCD? What are their kind of day-to-day experiences? And we wanted to kind of get a breadth of views. So we interviewed parents who were yet to seek support for their child's difficulties, those who were on the wait list for support for their child, those who were in treatment already, and those where families had previously received treatment. And so what you can see on the screen here is kind of a figure really that shows an overview of the results of this study. And I'll go through some of these in a bit more detail. But overall, what we really kind of grasped from these interviews with parents is that it's really challenging to parent a child with OCD. Parents often find OCD very frustrating, very hard to understand, and parents often feel helpless. They don't know what to do to support their child and what to do for the best. And that was really evident kind of across all participants and across throughout the interviews as to what parents were telling us. And there were some other kind of key themes that came up across participants, which I'll speak through a bit more now and give you some examples of what parents were telling us. And the aim really of going through this research with you is to, if you're a parent, perhaps normalise your experiences so that you know you're not the only one who's going through particular challenges with their child. And if you're a teacher or perhaps a healthcare professional, to get a better insight and understanding as to what it's like to parent a child with OCD. So the first kind of theme I'm going to go through is the sense of parents' journey to understanding and coming to terms with OCD. So parents often found OCD really hard to understand. Parents were often unfamiliar with OCD. They didn't really know what OCD was. And they weren't sure what was kind of normal developmental behaviours in terms of tapping or touching things several times, and what was OCD. Parents also found OCD to be really irrational, not really understanding the logic behind OCD, which made it very hard for parents to be empathetic to their child's concerns. And we can see this sense of irrationality of OCD in a quote from a father here that spoke about an example where they'd been out for a walk and his daughter had touched a branch. And she was worried that maybe a dog had gone near that branch and got really upset about the thought that perhaps she could have touched dirt or poo. And the father saying that it's so remote, the chance of that happening. So really kind of illustrating that it's hard to understand, it's irrational, and parents just sometimes don't get it. But despite this, parents often spoke of the importance of understanding OCD to be able to help and support their child. And so we've got a quote from a mother here saying that if you don't fully understand OCD, it can be really difficult to support someone who's struggling with it. And understanding OCD was often seen as the first step or the key as to helping their child, and often help parents to start to respond differently to their child's difficulties. So feeling perhaps more empathetic rather than frustrated at their child's challenges. And we can see this from the quote here from a father who says that what made the biggest difference to him is to understand how OCD works. It tells you stories, which we all know are not true, but for that person, they are true. This thing to understand. So the next kind of theme that arose from the interviews was this sense of parents really having to battle to get support. And I'd be interested to kind of hear parents' experiences here, if it differs in the US versus the UK. But there really is a difficulty kind of accessing treatment in the UK, and parents might often wait sort of a year to 2 years to receive professional support. And I think that was really kind of reflected in the interviews. So parents often felt like they were in a real crisis and that nobody was helping and they weren't able to get professional support. And this often meant that parents felt they had to rely on themselves to try and, parents were often desperate to find any books, or perhaps they knew a friend of a friend who was related to psychology. And we can see that in the quote here, where a mother said, any input would have been useful. We did it all off our own back. We didn't have any support with any of it. Everything we did was what we'd read on the internet. And even when parents were able to kind of get through the front door and to access support for their child, some parents perceived the support they received as inadequate, and that their therapist wasn't well equipped to support their child with their needs. Which we can see from a quote here. So it's quite insulting when a professional who hasn't been there at 3 o'clock in the morning, when your child is blinking at the ceiling, otherwise they're going to be a lesbian, telling me she hasn't got OCD. And so for the parents that we interviewed, there really was a sense of a battle for getting support, and also for some parents, a battle when they'd got that support as well, in terms of getting the right support and the right therapist. The next theme that kind of came out of the interviews, which I think is really important for any kind of clinicians or mental health professionals who might be here this evening, is parents' kind of sense of navigating how to respond to OCD. So parents often really didn't know how to respond to OCD. As I mentioned earlier, we know OCD can be sneaky. It can get other people involved in its compulsions. And so parents often didn't really know what they should be doing. So should I be getting involved in these compulsions? Should I not? How do I respond to my child? And we can see this from a father here who said, at each moment at home, you're never really quite sure what to do. What is the right thing? What is the most helpful thing, irrespective of whether it's difficult or not? What is the most helpful thing in the long term for her condition? And knowing that is difficult. And parents often kind of described how they felt a sense of conflict, both within themselves and perhaps with parents in the house having different views on how to respond. So parents didn't know whether they should be getting involved in their child's compulsions or whether they should sort of stop and not do that. And typically parents that we interviewed did often get involved in their child's compulsions, but they did so because they felt they had to help their child to function for the day. So to be able to get their child to go to school or to go to sleep on an evening. And we can see the sense of conflict in this quote here. So we've got a parent saying, it was a real conflict with myself because I knew it wasn't helpful, but especially in the morning, I needed to get him to school. And he wouldn't leave if I didn't do it. I had one morning where I wouldn't reassure him about putting his clothes on. I came upstairs 15 minutes later, he's got no clothes on, he's crying. What do you do? I need to get him to school, I've got other children, I can't have a standoff, and he's distressed, which as a parent you don't want to see. So really kind of highlighting that conflict of knowing perhaps maybe I shouldn't be doing these behaviours to help the OCD, but feeling they had to get their child to function for the day. Some parents spoke about how they tried to help their child to kind of stand up to OCD, often with the support of a therapist. And parents felt more confident and more equipped to help their child with compulsions that they perceive to be more kind of concrete or physical. So perhaps compulsions around sort of washing hands or asking for reassurance, compared to ideas that they thought were more kind of abstract or less physical. So perhaps if their child had worries about becoming a bad person, for example. And we can see from the quote here, so let's try and not wash our hands and touch that and see what happens. Seemed a lot easier to manage. And another parent saying, maybe next time I'll just give you 3 reassurances rather than 30. So those compulsions that seemed a bit more concrete were often seen as something that was easier to help their child with at home. OCD was also seen as really controlling by parents. So parents described how OCD not only controlled their child, but also controlled the parent and the wider family life as well. So I guess thinking about the child, first of all, We've got a mother here saying it's just constant. To get her out of bed in the morning can take her 2 hours. She has so many thoughts and rituals, like gulping, long blinks, saying a chain of thoughts without blinking, and then blinking at the end. And that's just getting out of bed. And I think this quote really nicely highlights how OCD is really kind of impairing and impacting on this child's life, and the interference that it's causing. And parents also spoke about how OCD controlled their child in terms of their characteristics. So parents described how their child's personality seemed to change with OCD. So going from being a very placid, very affectionate child to being quite angry and aggressive, which we know is quite common in children with OCD. So OCD as well was also seen to control the family. So we've got a father here saying that OCD had wrecked family life. The way everybody used to interact changed an awful lot. As parents, you try and keep the harmony between everybody, and it was very difficult to get that. And some parents as well spoke specifically about how OCD started to impact their other children or siblings. So we've got a mother here saying, it was more about the length of time I would spend with him that I couldn't spend with other children. It certainly seemed to affect one of the other children, definitely. So really highlighting the impact that OCD has on the whole family system. And then the final theme that came up from the interviews was this sense of a bit of an emotional roller coaster that parents went on. So parents really described an array of emotions that they experienced, from feeling very upset and finding it very challenging, to parents feeling understandably a bit overwhelmed, struggling to cope on a day-to-day basis. As well, parents felt very worried, both now about their child's OCD and worrying whether it might get worse in the future. And this led to some parents feeling like they'd failed their child, and feeling like a failure. So really difficult kind of emotions for parents to try and manage in these situations as well. But I wanted to kind of end this part of the research on a happy note, or a note of kind of hope. So although parents have really described kind of the understandable challenges, frustrations, a sense of helplessness at helping their child, parents did note that things can and do get better, often with the support of the right therapy and the right therapist. So we've got a parent here saying, at the moment, we've had massive success in tackling it. Life is much easier for everyone. Another parent saying that they thought treatment is the best thing they've done for their child and for their family. And a parent saying they've had some really big breakthroughs with cognitive behavioural therapy, or CBT. Their child doesn't drink from water bottles anymore. She's able to drink from cups and glasses, so they can go into a restaurant and have a drink. And so I wanted to kind of leave that message of hope, particularly if you're a parent of a child with OCD at the moment, that other families are going through similar experiences to you, and that they've also managed to get out the other side and receive support that's helped their child. And so the messages that I'd like you to kind of take home from this research, if you're a parent, is that you're not alone. Often parents tell us they feel very isolated, and they feel like they're the only family in the world that are kind of going through these difficulties. And so hopefully by hearing other families' stories, it helps you to realise that other families have gone through similar situations to you. And also just to validate that it is really hard to parent a child with OCD. It's challenging, it's frustrating. Parents don't know how to respond in these situations. So just to recognise how difficult it is. And perhaps if you're a teacher or a mental health professional, again, hoping that this research has given you some insight into what it's really like for families, so that you can have a better kind of understanding and empathy for the families that you might be supporting. And also it highlights the need to be able to give parents very practical guidance on how they should be responding in particular situations, to help parents feel a bit less helpless and to know how they should be responding to OCD in particular circumstances. So that kind of concludes where we've sort of gone through the research about parents' experiences. And as we heard in that research, parents reflected on how treatment was particularly beneficial for helping their child and for their family. So now we'll speak a little bit about effective treatment for children and young people with OCD. So in terms of psychological treatments, the evidence base is for cognitive behavioural therapy, or CBT, including what we call exposure and response prevention, or ERP. And so CBT, or cognitive behavioural therapy, is based on the idea that our thoughts, feelings and behaviours are all interconnected. And so when we experience mental health difficulties like OCD, anxiety or low mood, we can have particular ways of thinking and ways of behaving that might keep those symptoms going. And so cognitive behavioural therapy helps people to challenge and change the ways they think in particular situations and the ways that they behave to start to break out of that cycle and alleviate the symptoms that they've been experiencing. And so, as I've mentioned, cognitive behavioural therapy is the recommended evidence-based treatment for children and young people with OCD. And so what that means is that research has shown that this treatment is effective at reducing OCD symptoms in children and young people. And it's been shown to be more effective than other treatments, such as relaxation therapy. And much of the research looking at the evidence base for this treatment has been conducted here at UCLA by Dr. Passantini and colleagues. So what should cognitive behavioural therapy look like? So if you're a parent kind of wondering what this might involve, am I getting the right support for my child? First of all, CBT should involve an assessment of your child's obsessions, so their unwanted thoughts, images or urges, and their compulsions, so things that your child has to do in response to those obsessions. So that the therapist has a really good understanding of what's going on and can tailor the treatment to your child. And then a really core component of the treatment, and should often make up a bulk of the treatment, is what we call exposure and response prevention, or ERP for short. So what is exposure and response prevention? So this is all about exposing young people to their obsessions, so their unwanted thoughts, images or urges, whilst not engaging in their compulsions. And in children, this is often done in a very gradual step-by-step way. So often they'll start with tasks that are slightly easier and work their way up to tasks that will be more challenging. And so I've got a picture of a ladder on the screen here. Often in therapy, it might be referred to as a step-by-step plan or an exposure hierarchy, where at the bottom of the ladder, you'd have those easier tasks that I mentioned, working up to harder tasks. And the whole idea of exposure and response prevention is to give children an opportunity to learn what does happen if they face their fears and don't engage in their compulsion. Does their unwanted thought come true? Does something else happen? And also to learn about their ability to cope in these situations without doing their compulsions. So learning to kind of tolerate that anxiety or that uncomfortable feeling, and learning they can cope without having to do these compulsions. And so I thought I'd give you a few examples of what this might look like for some of the different presentations of OCD, to kind of ground it in examples so it's a bit easier to understand. So first of all, I'll talk through an example of a young person who might have obsessions or compulsions related to contamination. So they might worry about dirt or germs or perhaps sticky substances, and worrying that perhaps that might make themselves ill and make other people ill as well. And so an example of what their exposure and response prevention step-by-step plan might look like, you can see on the screen here. So the first step would be for the young person to touch somebody else's phone, which might have dirt or germs on, and not wash their hands. The second step might be for them to touch a door handle and not wash their hands. The third step might be a bit more challenging, perhaps going to a public place like a shopping mall and holding the handrail and not washing their hands afterwards. Then it might move to touching a known sticky substance and then to an unknown sticky substance without washing their hands. And all the time giving the child the opportunity to learn new information about their fears and their ability to cope without having to do these compulsions. And these step-by-step plans are going to be very individual for each child. So what's step 1 for one child might be step 6, 7, 8 for another. And so often therapists will work with you and with your child to identify some tasks to start with that might be a bit easier, working up to those more challenging tasks. So another example of what an exposure and response prevention step-by-step plan might look like for a young person with worries around kind of harm. So this young person might worry that if they say the words kind of murder, death, or poison, that something bad might happen to their loved ones. And so the first step on the plan might simply be to say those words, murder, death, or poison. And with children and young people, you can often try and make these tasks a bit more fun to make them seem a bit less scary to start with. So perhaps the family at home might sit around the dinner table and shout out the words murder, death, and poison over and over again. The next step might be to write those words down. And again, trying to make it appeal to your child's hobbies or interests. So perhaps they can do it in fancy glitter pens or big coloured paper to write those words down. The next might be to read a chapter of a book about murder or death or poison. And then to move up to perhaps writing a murder mystery story about their friends or family without having to do compulsions along the way. And then I put another example here where a young person might have worries about a particular number. So for this young person, they might really worry about the number 9. So if they do things 9 times, something bad might happen or it just won't feel right. And so they might find themselves doing things lots of times, maybe 10, 11, 12 times to make sure they avoid the number 9. And so their exposure and response prevention step-by-step plan might look first of all, perhaps tapping something 9 times and learning what happens and how they can cope with that discomfort. The next might be to look at a passerby 9 times or to write out the number 9 times. And then for this young person, we might want to introduce a bit of an element of uncertainty. So not knowing how many times you have touched something or picked something up. So they might have to pick up the TV remote an uncertain number of times, perhaps throw it between mum and them in the living room. And working up to a more ultimate goal of going to school and being able to go around and touch everyday objects an uncertain number of times. Maybe it's 9 times, maybe it's a different number, and being able to kind of cope with that. So hopefully that gives you a bit of a flavour of how for the different presentations of OCD, treatment might look. But we know OCD is sneaky. It can get other people involved in kind of keeping it alive. So it often likes to recruit other family members or perhaps teachers or friends or siblings involved in its compulsions. So for example, it might get other people to wash their hands in response to touching something. Or it might get parents to prepare their food in a particular way. Or perhaps it might ask the teacher lots of questions about whether things are going to be okay. OCD might also get other people to help facilitate avoidance, so avoiding things that might trigger OCD. Or perhaps getting other people involved in checking the door before bed. And I think it's important to say that it's really common that other people get involved in OCD. And it can be parents, it can be teachers, it can be siblings, it can be friends. And getting involved in OCD is often a really natural, understandable response to when a child is distressed. So if we see a child who's distressed, our natural response is to want to take away that distress and want to help them. And that can help in the short term, but in the long term, other people being involved in OCD can keep the problem going. So we'll kind of talk through a bit of an example of what that might look like. So let's take an example of a young person who repetitively checks the door before bed, and they also want the parent to check the door before bed. So the young person's about to go to bed, and their unwanted thought is, unless I check the door 3 times before I go to bed and get mum to check the door too, someone's going to break into the house and they're going to murder my family and it's going to be my fault. So that thought and that interpretation of that thought is going to make that young person feel distressed and feel anxious. And that's going to motivate them to check the door whatever number of times that OCD wants them to do, and is going to get their parent to check the door as well. So understandably, the child's feeling kind of distressed, they're anxious, the parent's now kind of thinking, you know, unless I check the door, my child's going to be really upset, that she won't be able to sleep, she's going to be tired for school the next day, she's not going to do very well in her work. The parent as well might start to feel a bit nervous or tense. It's not very nice seeing our child upset or distressed. And so understandably, in response to their child's distress, they might check the door with their child and tell them they don't need to worry and that nobody's going to murder them or their family in the night. And so this kind of gives the child sort of temporary relief. So they've checked the door, the parents check the door, the distress kind of comes down. But the difficulty is the child thinks that the bad outcome, so that the family didn't get murdered, was only because they checked the door. And so the child's act of checking and the parents' act of checking becomes kind of reinforced. The child thinks, phew, that only didn't happen because we checked the door. And they don't have a chance to learn what does happen if I don't check the door at night. Does somebody come in? Do they murder my family? Can I cope with that anxiety of not checking? And so the next night, when it comes to bedtime, the child's going to have the same thought again. They're going to feel anxious and distressed. They're going to be motivated to check the door. And the parent will go through the same cycle as well. And it becomes a cycle that continually reinforces itself. So although the parent's behaviour is well-intentioned and reduces the distress in the short term, it keeps the problem going in the longer term. And so for treatment to be successful, the therapist will often explore if other people are involved in the child's OCD. And think in treatment about ways that they can kind of gradually reduce other people's involvement so that it's manageable for their child and done in a step-by-step way that their child is involved in and aware of. And so I've got an example on the screen here of how we might gradually reduce a parent's involvement in this situation. So the first step might be for the child to just check the door once and the parent to check the door once. The next step then might be for the child to check the door once whilst mum's in the same room, but the parent's not checking the door this time. Then we might move to the child checking the door once on their own whilst mum's in a different room. And working our way up to the child being able to go to bed without them checking the door and without the parent checking the door as well. So that again, they have this opportunity to learn what does happen if I don't check the door? Can I tolerate the distress or the anxiety in this situation without doing my compulsion? But it's hard to do. It's hard for people who might be involved in the OCD to kind of step back in a gradual way. And so first of all, I just wanted to normalise that it can be hard. It can be upsetting to see our child distressed, and that can make us anxious as parents or as teachers or as siblings. So it's important to kind of take a bit of time out if you need to in those situations. And perhaps work as a team. So often parents that I work with might try and tag team together. So if a parent's working on a step with a child and they're feeling a bit distressed, they might swap out with the other parent and they take over and help the child in that situation. So kind of working, using your support network, whether that be another parent or another significant figure in a child's life. I think also in those moments when you're kind of feeling distressed, your child might be feeling distressed as well, is to remember the long-term benefits. So although there's distress now, you're working towards helping your child have a life without OCD and the benefits that come along with that. And so remembering that in the moment can be particularly helpful for a parent. So now we'll think a little bit about how parents can sort of more generally support their child who's receiving cognitive behavioural therapy treatment. So as we've kind of illustrated through these examples, CBT is a very active treatment. It's going to involve the child being exposed to their fears without engaging in their compulsions. And so often they'll have tasks to complete both within the session and also tasks to complete at home as well. And so the more that you're able to put into the treatment and the more that your child's able to put into the treatment, the more likely you're going to be able to see treatment gains. And how much parents might be involved in their child's treatment might really vary depending on the child's age. So for younger children, so maybe around kind of 6 to 10, 11 years old, parents might have a much more active role in treatment. They might attend most of the treatment sessions with their child. They might be really involved in helping to generate ideas for their child's step-by-step plan and helping to ensure that these steps happen at home. So they might have a much more active role in supporting or helping their child. Whereas if your child's slightly older, so maybe they're sort of 11 upwards, maybe your role is to be more of a supporter. So being aware of the tasks they might be working on that week, or perhaps giving them reminders to do their exposure task that week if they haven't already. And you can kind of negotiate your involvement with your child at that point, so that it's a helpful relationship for you both. And then, as we've mentioned as well, sometimes in treatment, other people's behaviour might be a target in treatment. And so parents might be involved and they might be advised on how to gradually reduce their involvement in their child's OCD, or how teachers might be able to reduce their involvement in the classroom. And so that might be another way that parents are involved in supporting their child. And again, some more sort of general tips on supporting your child in treatment. We know that it can be hard to face their fears, and they can experience some distress when they are having a go at their step-by-step plans. And it can be hard to know what to do as a parent in that situation. And sometimes just really listening to your child and helping them to feel understood can be one of the most important things. And so if your child is feeling anxious or distressed, simply saying what you see can be really helpful. So saying things like, I can see this is really tricky for you, or this is really hard. And encouraging your child, so showing belief that you think they can do it. So I know you can do this, you're doing a great job at fighting back at OCD, well done. It might also be your role to facilitate the steps that your child's been asked to do. So for example, if their step plan is about reducing the amount of time they're spending showering, your agreed role in that plan might be to monitor how long your child's in the shower and help them to reduce that gradually. And we also advise that parents and other people try not to reassure their child or distract them whilst they're having a go at a step on their step-by-step plan. And again, as a parent, if your child's kind of anxious or a bit distressed, you might want to sort of change the topic of conversation, or tell them that things are going to be okay if they do this step. But really, it's important for children to try and experience that anxiety so that they can learn that they can cope with it, and that they can tolerate the anxiety in that scenario without having to do their compulsion. And then finally, kind of praising and rewarding your child for their achievements can be really helpful. So often young people or teenagers might not see the long-term benefit of engaging in treatment or fighting back at OCD. It can be a hard thing and a scary thing to do. And so praising your child for having a go at the steps on their plan can be a really powerful way to help engage them and motivate them to start to face their fears. Rewards can also be really helpful as well. And rewards don't have to be monetary, they don't have to be very big. Often it can be helpful to perhaps have a reward that meets the level of difficulty of that step. So it might be things like staying up half an hour later on the weekend for teenagers, or perhaps popping to the sweet shop on the way home from school for younger children. So thinking about, is there something your child's motivated to work towards for each of these steps to help engage them and encourage them to have a go at facing their fears. And so really that kind of brings us to the end of sort of the main content that I'm going to speak about tonight in terms of what OCD is, how it impacts the family, what treatment might look like, and how parents can support this. And so if you did want to kind of look for further information or more support, there's a couple of websites here that might be helpful. So the International OCD Foundation and our CARES website has more information about OCD, and also information on where you can find treatment or a therapist. I've also popped OCD UK on here, which, although is a UK charity, have really helpful information on their website, particularly for parents. They have quite a lot of webinars similar to this, focused at parents, and really practical advice on things that parents can do, as well as ways that parents can kind of look after themselves in the journey of supporting their child. And then finally, I just wanted to acknowledge the families who participated in the research that I've spoken about tonight, the supervisors who were involved in supervising the research, the UCLA Child Anxiety, OCD and Tic Disorders Programme, where lots of the research about the evidence base for CBT has come from, and also UCLA Cares for hosting the webinar tonight. So that's everything from me. So I'll open up the floor to any questions.
Hi, Chloe, that was amazing. What a very informative talk. I even learned some of this, and I've been doing this for a while. You had some really nice ideas and information there. There are a couple questions. The first one is, how can you work with a teenager who may have other issues like depression or anxiety, mm-hmm. and may not want to do treatment either because they're afraid or they don't think it's going to work? There are things that you can do to help the parents encourage the child to come into treatment, or actually working with the child, him or herself?
I think it could be a tough one when there's kind of other difficulties going on as well, particularly sort of the depression or anxiety. And often OCD can be sort of the bigger problem and might lead to other difficulties like depression and making it harder to kind of get out and do things. So I think maybe it's about kind of discussing with the young person what they would like to be different, or what life would be like if they didn't have these difficulties, and maybe kind of setting a goal around what they would like to work towards. And maybe that might be a bit of a motivator for them to perhaps think about or start to engage in treatment.
Good, thank you. And what, you've talked about this a little bit, but could you talk a little bit more about what parents can do to support themselves, given the stress of dealing with a child with OCD, and maybe especially under the situations where they're unable to find help for the child and they have to manage at home without help, that therapy?
Yeah, I think kind of as we've seen from the research, it's really hard to parent a child with OCD, particularly in these kind of times where it might be hard to access support. We've also got the kind of pandemic going on. And so it is really important that parents do look after themselves. It's a bit like thinking of the analogy that if you're on an aeroplane, if the oxygen masks fall down, you have to put your own oxygen mask on first in order to be able to help your child. And so looking after yourself as a parent is really important. And so it's kind of what works for you as a parent, really. There are some helpful resources online about kind of self-care for parents. So thinking about maybe 1 or 2 small things you can do as a parent to have time to yourself, or to have a bit of kind of time out. The OCD UK website that I mentioned at the end has a specific talk on how parents can look after themselves and about self-care in the context of parenting a child with OCD. So I'd signpost you to that as well, particularly around kind of self-care for parents.
Yeah, and there's some information on the CARES website also. And one person put in the chat, it's okay, actually, there's another question that relates to what you just answered. Mm-hmm. This is a really important question. And thank you to the person that posted this. How can parents support the other children in the family? OCD really can have a pretty devastating effect on families and take a lot of parents' energy. So oftentimes it's the brothers and sisters that are also impacted.
Absolutely. And again, from our research, which was something that we didn't anticipate coming up, was parents really talking about the impact on siblings and other children in the house. And from the parents that we spoke to, they found that it was often helpful to try and explain the OCD to their child or to the siblings, so that they could understand kind of what was going on. And that often helped children to feel a bit less resentful or kind of not understanding why one child's getting so much attention compared to them. So perhaps maybe describing or explaining what OCD is to your other children. And then maybe if you can, I know it's hard as a parent, you've already got lots of competing demands, a child with mental health difficulties, but perhaps maybe trying to carve out even just 5 or 10 minutes a week to kind of spend sort of special time with your other children. Maybe having a conversation with just them after school, or perhaps taking them to the park on the way home just for 5 or 10 minutes. They've got that kind of special time with you as well.
Yeah, in our clinic, when we have younger children with OCD that are working, or even older children at times that are on reward systems, they get rewards, whatever kinds of rewards for going to therapy or doing their homework. We work with the parents and try to help them develop reward programs for the other kids as well. So everybody's working towards some positive goal and can get some rewards for that. One more question. It's really hard to find a therapist that has experience with CBT and OCD that accepts insurance and then accepts new patients. It's very difficult. And, you know, this can really impact school. In some cases, you know, the rituals of getting ready for school or getting out, or nighttime rituals, it really can be very difficult in that case. Do you have any, I know you've talked about this a lot in your talk. Do you have any other words of wisdom or support for families that can't find treatment and whose, you know, the home system, you know, is really just being really impacted?
Yeah, I think just first of all to just recognize the difficult time that you're going through, and yeah, how it can be really hard to kind of navigate those systems. Like you say, trying to find a therapist who's got the accreditation, the experience, takes your insurance, and is able to take new patients on. So just to kind of empathize with that difficulty first of all, and then maybe to try as much to draw on any support systems that you do have. So perhaps liaising with the school and see if there's any support that they can give. Might also be worth looking at some kind of self-help books as well. I don't know how old your child is, but I've heard good things about the book, which is called What to Do When Your Brain Gets Stuck, which is quite child-friendly. So you could try and think about some self-help resources that might guide you on ways that you can start to help your child whilst you're kind of waiting for that therapist input.
Okay, a couple more questions are really coming in now. How young can you go with treatment?
I mean, you can go as kind of as young as the therapist can identify, really. Typically, OCD often onsets around kind of 7 years old, but it can be seen as young as sort of 5 or 6 years old. But often it kind of takes a while, maybe for parents to kind of realise what's going on and that perhaps maybe it's problematic. So we don't tend to see the presentation too young in children, but yeah, you can definitely work with younger children from sort of 5 upwards, but particularly the work will predominantly maybe be through parents, so kind of guiding you and giving you that support on things that you can be doing at home to support your child.
Yeah, we've seen kids down about as young as 3 or 4, very rarely, but it does, in some cases, it can start very early, but you may not be recognized as OCD. So if a parent of a young child, like 3 or 4 or 5 or 6, starts to see something that they think might be OCD, but they're not really sure because the child's so young, do you have any recommendations or tips on what they can do to maybe help that child?
Again, I think trying to reach out for support early on if you can. I don't know what the situation here is like with wait lists, but yeah, reaching out for support if you can. And also perhaps again looking at kind of self-help books. Often it's easier to kind of nip the difficulties in the bud when they first start rather than when they start to get a bit more entrenched.
Yeah, with younger kids, we oftentimes will recommend to, you know, very gently redirect the child. If the child is anxious or engaging in some compulsions, you don't want to draw too much attention and make the child feel bad. But there are some ways of gently redirecting or distracting the child, perhaps, and engaging them in, say, maybe a more fun game or a fun activity. And, you know, that may be something to do for a bit. Another question about medication. Do you think medications are helpful? I can answer this one. We use medication with a number of the children in our clinic, even relatively young children. I think it's important to note, though, that the CBT we consider the primary treatment intervention. The CBT is what's going to lead to lasting change. But in some cases, if the OCD is so strong that the child is too anxious to really try the CBT, then we would use medication to reduce the anxiety to the point where we can do CBT. And in fact, the research suggests that on average for kids with moderate or more severe OCD, CBT plus medication is actually the most effective way to go. But whether you add medication or not is really an individual decision based on the symptom presentation of the child. For children with very strong anxiety or depression, that might be one reason to try medication, since it's the same medications for OCD, anxiety, and depression. You know, one medication can actually help all of those. I think we have time for 2 more questions, and then we're running up against the hour. There's a vicious cycle where OCD symptoms worsen sleep. nighttime rituals can really impact sleep, and that can make the kids not get enough sleep, which can make them crankier. And in some cases, it can worsen their OCD.
Yeah.
How do you break that cycle?
Yeah, I think definitely, like you said, it can be hard if they're kind of doing compulsions into the night, it's impacting their sleep. And often when we know, you might notice yourself if you're a bit tired, a bit more difficult, and that's kind of heightened really with OCD. And so again, it's thinking about how do we break that cycle, and thinking about the exposure and response prevention elements. So what are some kind of gradual ways we can start to expose your child to their obsessions whilst not engaging in their compulsions? And sometimes maybe bedtime isn't the best place to start. It might be easier to start with something in the daytime, to kind of experience that success and gain some confidence in fighting back at OCD. And then kind of later on working around kind of times around bedtime or getting to school on time in the morning.
That's great advice. And then one final question would be, have you worked at all with children with OCD that are on the autism spectrum?
Personally, I haven't, but we know that autism comes alongside OCD very commonly. The evidence base still stands for children with autism, but often the treatment might need a few more kind of adaptations or perhaps longer treatment. So I personally haven't worked with children with autism and OCD, but it is very common in clinical practice.
Right, and it probably requires somebody that specializes in autism and OCD to be a much more behavioral treatment.
Yeah.
There was one other question. Somebody had asked about treatment. In our clinic, it's very difficult to get into our clinic. We have quite a long wait list of over 100 kids right now. But we are really in the midst of an expansion where we've hired some new therapists, clinicians, and we're also developing a series of group treatment programs, both for children and for parents. So if you have contacted the clinic and you are in the waiting pool, we may be reaching out. We're actually being able to move a little bit more quickly getting people in treatment with some of these new programs. And if you're calling in for the first time, we might have some alternate treatments to offer you in terms of groups and all. But it's the need is overwhelming, and the resources are just unfortunately just about everywhere and anywhere not up to the task. But we are working on this, and I know other providers are as well, to try to help as many people as we can by providing effective therapy one way or another. So, Chloe, thank you. This was a wonderful presentation, very informative, and so nice to have you here from the UK. You're leaving. You have 2 weeks left, and we're really going to miss you when you go back home. And I know you're going to miss the sunshine too.
Definitely.
Great, thank you.